Let's begin our discussion of psychotropic neuroleptic meds with the mood stabilizers. You will see on your list of slides a slide before this one that gives you the classifications of medicines that we are going to discuss. But for the sake of brevity, I'm going to move right along and start with mood stabilizers. Uh, I'm going to list the ones I think are most important for you. They are lithium, Depakote, Tegretol, Topamax, and Neurontin. Although Neurontin's been getting some bad press lately, many people still feel that it is extremely helpful. Let me talk about each of them individually for a little bit. First, lithium. Now, the purpose of lithium is to reduce the lability of the bipolar patient. Uh, It takes a little time to work. You have to test the patient's blood levels regularly, and the blood levels must be between 0.5 and 1.2. Otherwise, you're going to have all kinds of blood pressure problems, other problems. Uh, let's now look at the skin, which is going to be much more susceptible to ultraviolet rays if you're taking lithium. Again, bipolar disorder, acute manic episodes, these are the people who are most likely to be taking lithium. The patient should be advised to wear heavy sunscreen, maybe a 50, and dark glasses, perhaps a hat wouldn't be a bad idea. Uh, Side effects of the drug are listed here. Hypersensitivity to the drug could lead to cerebrovascular or renal disease. It should only be used where therapy can be closely monitored. You have to regularly check those blood levels, and some products which contain alcohol should be avoided, and in fact, alcohol should be avoided at all cost with these drugs. Lithium toxicity can occur, as can toxicity with so many of these drugs. The symptoms you're likely to see are severe nausea and vomiting, confusion, slurred speech, the things you see listed here. You should monitor the patient's mental status and mood for suicidal thoughts. You should monitor those lithium levels twice a week, and once they're stabilized, every 3 months. There's a very narrow therapeutic window. We have to be, as healthcare providers, always aware of that. We should also test for thyroid and kidney damage every 6 to 12 months, because taking lithium over long periods of time can lead to difficulty in those areas. You should also know that with lithium, weight gain can be significant, and a lot of patients will resist taking it for that very reason. We have to work with those people because lithium can be a tremendous help to individuals who are suffering from bipolar disorder, and maybe we can work with them regarding diet and exercise in order to help them. Next, we have Depakote. Depakote also is designed to stabilize the moods. Originally, it was used as an anti-seizure drug, and in fact, sometimes it still is. It serves several purposes. Now, once you've begun giving Depakote, you cannot stop giving it without weaning the patient off it, because to abruptly stop Depakote can lead to seizures, and serious seizures. Side effects of the drug include those listed here. Again, increased appetite, increased weight gain. You need to monitor your Depakote levels regularly, maybe every couple of weeks, monthly after the patient is stabilized. But people on these drugs need to be carefully watched. Let's look at the benzodiazepines now. The ones we want to look at, well, I'll get that list shortly. About benzodiazepines, first and foremost, we use them to treat anxiety, insomnia, tension, muscle spasms. Their purpose is to provide mild sedation and relief from tension and anxiety. The kind we usually see are Valium, Xanax, Transine, Ativan, Klonopin. You've probably heard all of these names before, and Buspar especially being very popular for people with, now I can't think of the word, not, well, that's good, isn't it? Look up Buspar and find out what it is specific to. It's an anxiety issue, and the word is right at the tip of my tongue. I'm sure you've all had this happen, just not on a recorder where you can play it back for everyone you know. Be aware, however, that Buspar should be looked up and you should become aware of it. Now, what are the side effects of benzodiazepine, in addition to the fact that it can be addictive? Over time, we should also expect drowsiness, slurred speech, confusion, difficulty breathing, nervousness, excitement, headache. Also be aware that these drugs can be deadly when you mix them with alcohol or barbiturates, because those will potentiate, increase the effect of the benzodiazepine. For short-term use, they can be very safe and effective, and by short-term, I mean a couple of weeks, 3 weeks after an event that has left a patient with severe anxiety. However, anything more than that, and they become dangerous. They can become addictive, they can be difficult to give up, and then you find someone who's been on these drugs for many, many years. So we really need to help patients make sure they stay within the parameters of appropriate use. Let's look at benzodiazepines a little more. Remember when we talk about addiction that people come to rely on these drugs to help them sleep and relax. It's so easy to fall into that habit of, oh, I need my Xanax tonight. Oh, it helps me so much, and I don't think I'll be able to sleep. And then anxiety comes because you didn't take your Xanax, and now you can't sleep. This is a vicious cycle that we should be aware of whenever we have a patient who has been prescribed benzodiazepines. Physically, again, the body becomes accustomed to the presence of the drug. Remember what we said, that you will never have the same feeling that you do the first time. The longer you take it, the more you will require in order to get the same effect. So, be aware that that can be a serious problem. Never stop these meds abruptly. You've got to taper them down over a course of weeks in order to avoid any of the side effects and withdrawal effects that benzodiazepines can lead to. Those are pretty standard, but I'm sure that they're in your pharmacology textbook, and you may look them up should you wish to. Next on our list, antipsychotics. There are so many, they're so popular anymore. Let's talk about what they are. If you're looking at older types of antipsychotics, which are still some of them used, Trilofan not so much, Haldol, used but for the wrong purpose. We often see Haldol prescribed in nursing homes for the elderly. Um, it's not a good idea. Thorazine, still used. Stelazine, not so much. Clozaril, definitely used quite a bit, but it's been around a long time. L'Occitane, not so much. Mellaril, on and off. Navane, very rarely. Prolixin, very rarely. Because we have found new and better drugs that are safer long term for patients with psychotic disturbances. The newer types of drugs that we see used regularly now are risperidol, Seroquel, and Zyprexa. These you should see in psych, and you probably have often seen them in med-surg because so many people who might be thought of as mentally ill have their disease under control because of the antipsychotic drugs that they take. So, what are they taking them for? First of all, to correct disorganized thinking. When we talk about schizophrenia, uh, what disorganized thinking can lead to, what it represents, will be discussed in the classroom. Um, the purposes of these antipsychotics is to help decrease the patient's excitability, improve their ability to communicate, to lessen confusion and withdrawal, to improve especially their ability to separate reality from fantasy, in other words, delusions, and to control hallucinations. Every time we use an antipsychotic and help a patient to move forward in separating from these disorders and from the signs we see here, we're doing a good thing. Now, antipsychotics can have a lot of side effects. Often you'll hear about people with mental illnesses who really don't want to take their meds. They're so uncomfortable with it. Uh, and that's because the side effects are so serious, sometimes worse than the disease. Lethargy is one. And when I say lethargy, I mean like don't have the energy to get out of bed, can't leave the house. Hold on. Just a state of such exhaustion that the patient can't do much of anything. With that lethargy comes sleepiness. Families will complain actually that the patient spends so much time in bed, spends all day in bed, and we need him to get up, to get out, to get a job. What they don't realize is that often the medication they're taking is what leads to these issues. Over time, the patient may make some adjustment to the medication and do somewhat better in terms of taking it. But you remember the reading we did in the classroom. The patient never comes back to more than halfway of where they were when they first became ill. Dry mouth. For that, we can recommend mints or hard candies. Blurred vision, a very disturbing side effect, but one which is not uncommon, and a good reason to change a medication would be blurred vision. Of course, the patient will stop their meds if their vision is impaired and they cannot drive and they can't go out of the house. They will stop taking their meds. We need to be on top of that. Constipation, we can help them with that issue with Metamucil, with Miralax. There are a whole number of meds. Constipation is because of the drug, not because of their diet or their lack of fluid intake or their lack of exercise. Rather than get into any of that, they have enough to carry. I just recommend that they use either Metamucil or something of that nature to start, and if that works, great. And if it doesn't work, go to Miralax, which is quite useful. They also feel quite jittery on these antipsychotic drugs. Um, it's just a side effect of the drug, and again, if the patient becomes unusually excitable or jittery, we want to know that so that we can consider how to change the dosage or even the medication should that become necessary. Tremors. Patients will definitely present with tremors. Lithium is a drug that really, literally leaves the patient in a situation where they cannot pick up a cup of coffee with one hand. They can take only half a cup and need two hands to lift it up to drink it. Um, this is unacceptable. Again, we have to be on top of that. Patients who take these antipsychotic drugs should be seeing their psychiatrist or their psychopharmacologist on a weekly or 2 weekly basis, whatever is necessary. We need to intervene early. We don't just let people wander around the community wondering what they can do about these problems. And then, of course, there is rigidity. Um, Something you want to watch for. The muscles just become so stiff. Also, what I don't have here, I don't think, is tardive dyskinesia. Tardive dyskinesia is a side effect that's very, very serious because how it is when you find it is how it stays. You cannot reverse the effects of tardive dyskinesia, and it results in the patient making grimacing facial expressions, losing control over his tongue, losing control and having tics and other facial issues. This is a very serious problem, and so we have to watch for it carefully. Make sure that tardive dyskinesia is not a problem for your patient. How will you recognize that? Usually it starts out either with a small tick around the eye or a slight emergence of the tongue, lots of lip licking, and then it just gets worse. So you need to, if you know that your patient is on an antipsychotic and you see these symptoms beginning, you should please intervene quite early. Better to check it out and find there's no problem than to just let it go. Let's continue with our antipsychotics. We want to watch closely for the following issues. Dyskinesia, that's the rigidity I talked about. Akathisia, which is restlessness. Cogwheeling is a specific muscle rigidity of the upper arm. There are examples I think on YouTube that you could look for. Plug in cogwheeling and it will show you a picture of what that looks like. For people having these antipsychotic side effects, we can give Benadryl, Cogentin, Artane. Oh, and here is tardive dyskinesia indeed. So I did bring it up, but you should look it up as well, just to be sure that you have that firmly in hand. When you look at this list, it makes it more clear to you, I hope, why patients give up their meds. Now, note that these antipsychotic symptoms are links for you to use to learn more about them. I would go to those places and definitely take a look. Now we wanted to go on to antidepressants. Let's start with the MAO, monoamine oxidase inhibitors. These include Parnate and Nardil, which I said before are not used very often. The reasoning behind this is that they're very dangerous drugs, and one misstep, one accident in terms of diet can lead to significant problems. MAO inhibitors require a specialized diet. You see the list before you. No aged cheese, no pickled herrings, no barbecue. It's not listed, but no barbecue, no bananas, no chocolate, no red wine. Eating any of these items can lead to a huge increase in the blood pressure and hypertensive crisis that can actually cause a significant stroke. we'll talk, when we talk about this in the classroom, we'll talk about a friend of mine who had been on Nardil for 12, 15 years and had done beautifully on it. And then one day she was at an event and she took some slices of cheese. And within the hour, she was in the emergency room with a blood pressure of 240 over 170. She was brought out of this without any lasting damage. But when I asked her why she did that, she said, she never even gave it a thought. She'd been taking these drugs all her life. I asked her if she had ever done this dietary mismanagement before, and she said no, she never had, but she just looked at the cheese. It looked really good. She thought she'd like just one slice. What could happen? Well, you see how important it is that we follow the diet for people on MAO inhibitors, Parnate and Nardil. The side effects of MAO inhibitors, in addition to the possibility of hypertensive crisis, decreased blood pressure. That's if you just are taking the drug without violating any of the dietary rules. Just the drug, no violation of the diet, and your blood pressure will drop. That is considered a side effect. Drowsiness is a side effect. Constipation, you can get a rash, a full body rash. And please be aware that failure to follow the dietary regimen, I know I've repeated myself quite a bit, but like tardive dyskinesia, it's just so important to make sure that a patient on MAO inhibitors is not given the wrong food. That happens in hospitals, by the way, more than you know. So please keep your eyes open. Let's move on to tricyclic antidepressants. These are people who have decreased energy, some anhedonia, which you remember is an inability to feel pleasure, and decreased appetite. Sometimes that basic depression can be relieved by tricyclic antidepressants. What are they? Well, norpramine, Elavil, and Pamelar are three very popular, Elavil especially. Be aware that patients who are taking these should never mix them with alcohol or barbiturates. The outcome could be very, very serious, including death. And major side effects include dry mouth and constipation. That seems to be a problem with almost all of these neuroleptics. So it's a good idea with your patients who are receiving them to do regular bowel checks, talk with them about bowel function, and make sure that their diet and medications are not interfering with their bowel movements, but actually helping that to have a more normal outcome. SSRIs, everybody's most popular drug in the world. Where do we see them? Everywhere. Selective serotonin reuptake inhibitors. What do they include? Prozac, Paxil, Zoloft, Luvox, and Celexa. Everyone has heard of these. For regular dosages and other things like that, you need to look that up. But when we are looking at NCLEX, these are the drugs, the ones I've gone over here, that you are most likely to see there. Side effects: jittery, decreased appetite, decreased sleep. They elevate the way you feel. They make you happier. Now, the last thing I want to talk to you about are some atypical neuroleptics that you're likely to see used by your patients and that you should be having some awareness of. Among them are Effexor and Effexor extended release, Wellbutrin and Wellbutrin slow release, Trazodone, Serzone, and Remeron. These are not usually used. Uh, they're atypical because they're not usually used for these uh, psychiatric conditions, but I would certainly say just take a look at them and see what we can do to make sure that the patient is being treated appropriately in terms of uh, diet, bowel function, anxiety, and all of the things that we've talked about up till now. If you have any issues that you want to talk about or questions, please don't hesitate to ask. This has only been just to kind of get you moving and to uh, give you an idea of what are some of the issues that we might be looking at on NCLEX. So thank you very much. If you have questions, let me know. I hope this goes well for you.